Symposias are again related to the art and therapy regarding the theme, fitting to the theme of the conference. Now, we call upon Dr. Harish Kulkarni and his team to present their symposium. For this, we have a chairperson, Dr. T.M. Raghuram sir, who came all the way from Calicut. We request sir to chair this session. First, we call upon Dr. Harish Kulkarni and his team to present the symposium.
And oral paper. Now we are here for the symposium. So respected chairpersons, is it audible? Okay, you want this mic? Madam. So respected chairpersons, we are here with our symposium today. One of our speaker wasn't able to make it, so we are only two speakers today for the symposium, and we'll be covering the session. So the topic of the symposium that we are presenting is the Reel Review, exploring critical review of movies as an educational tool for postgraduate psychiatry training. So we have two presenters here. So myself, Dr. Sushma Inamdar. So firstly, I will be talking on the cinematic pedagogy in psychiatric education. Is it effective? So I'm sure from this image you can see that how the kids are listening to the narration of the story so interestingly. Yes, so storytelling has been found as one of the important educational strategies, and films represents its most visually and emotionally potent form. Cinema has long been recognized one of the powerful artistic and cultural medium which has the uniqueness of capability of capturing the human attention, shaping emotions, and also influencing the societal attitudes. So within the medical education, especially in the psychiatric training, it has emerged as a valuable pedagogical tool. And it also offers an engaging, vivid, and accessible way to explore many complex aspects of mental health. So by incorporating movies or cinema education, it has reflected a broader shift towards integrating both the artistic and the scientific elements in training. Of course, it has emerged as a promising innovative educational tool as it complements the conventional lectures. It also aids the students in connecting with the material both cognitively and affectively. Because of movies being having aesthetic richness, narrative depth, and emotional accessibility, educators have the ability to explore complex aspects of empathy, ethical issues, social context, and also stigma. So which of these things cannot be taught to the learners individually by only traditional methods of teaching. So with all this now, I'm sure that you know the strengths of using movies as an education platform for the learners because of its multisensory mode of learning, and also the audience, the viewers get highly engaged watching the movie, and sometimes it becomes more interesting rather than reading a book. So it can have even good memorability, and there's a safe exploration of sensitive issues with no confidential concerns. As I mentioned, even the complex information can be presented in a very efficient way. The learners can also understand the patient's perspective because they can understand the lived experiences of the patients. So which definitely adds to the essential layer of realism, and it is also a nuance to the training. As I mentioned, also it helps in explaining or teaching the complex aspects like empathy, stigma, ethics, and also the societal attitudes. So on a lighter note, it can even improve the students to the field because of its rhythm, dynamic and emotionally rich and socially relevant way of educating or teaching the learners. So currently, these are all the domains wherein cinema education has been used in psychiatric training. Firstly, in mental status examination and diagnosis, wherein the learners can vividly memorize the findings without breaching the confidentiality of the patient. So many movies have been used for the learners to teach about the doctor-patient relationship. So which helps to stimulate the discussion of communication styles, empathy, boundaries, transference and countertransference, and also shared decision making. In psychopathology and subjective experience, here the learners can get the subjective phenomena which can be understood by the real life scenarios, wherein they can also, which can be complemented along with the literature descriptions. So they can grasp the lived experience of the psychiatric disorders by watching the clippings. So it also helps in teaching them the cultural context and the social attitudes. So which helps us, the learners, to understand the prevailing cultural norms and stereotypes that is present in the society. And it also helps the clinician to appreciate the societal expectations and biases which are present around the mental illness. As I mentioned, of course, it improves the empathy of the learners. So when we try to understand that in the literature how cinema education has been used for teaching psychiatry, so we came across certain studies which were published, and then we understood that most of these cinema education models were used to encourage the learners to critique the accuracy of symptom portrayal in the movies, to evaluate the therapeutic interactions, and also to identify the stereotypes which have been depicted in the movies, and also to explore about the ethical and cultural implications. The formats under which these training was done using cinema education programs, psychiatry film clubs, panel discussions, and semi-structured reflective groups. Though this has gained widespread acceptance, there is always a systematic evaluation which is still not present, which is one of the limitations of doing this cinema education to the psychiatry trainees. So currently how these movies are being reviewed, the educators, they try to select one of some movies or the clip of movies with certain learning objectives. It can be either to illustrate a disorder or exploring doctor-patient relationship or even the societal or cultural attitudes towards the mental illness. So once the movie is watched, the trainees are allowed to participate in semi-structured discussions, reflective exercises or panel discussions. So I just mentioned that though these method has been widely accepted, it lacks the limits the standardized evaluation. So to summarize what I just presented, so cinema and psychiatry has always shared a mutual fascination with mind, behavior and society. So film-based discussions can definitely stimulate empathy, reflection and critical thinking. The thoughtful scientific integration of movies into teaching can definitely help us to add both artistic and scientific elements in the training of the learners. But as I just mentioned, there's also a lack of standardization which is present, which limits the effective learning. So to take forward about this, I have next presenter, Dr. Harish sir. Thank you.
Yes, and all my friends here. I thank my earlier speaker for briefly putting up the need for the innovative educational tool that is movie in psychiatric education. Okay, so I will be continuing the presentation with the framework that we have developed in our department. So this is what we have developed, the real review framework. I am Dr. Harish Kulkarni, professor in Department of Psychiatry, SNMC, Bagalkot, Karnataka. I'll start my presentation with a quote from Walt Disney, who believed that movies have tremendous influence on youngsters' mind, especially in developing the concepts, ideals, and objectives for their adulthood life. So with this, what we can see, as previous presenters already established, that cinema education is an effective educational tool in psychiatry. Yeah, but any cinema, if we show them and we ask, what did you learn? It is not effective as long as reflection is happening. So what is reflection? Reflection is a scientific analysis of an experience. So if I participate in this conference and I go home and somebody asks me, what did you do? So how was your experience? If I critically and scientifically evaluate what happened, then it is called a reflection. So reflection can be presented in various forms. One of the most commonly that in medical education, what we follow is Bolton's model, in which there are 3 questions posed. First question is, what happened? So I narrate what happened in this conference. So what? What this happened? So what? So I'll extend my vision to what will this result to. And the third question posed by Bolton was, what next? So what next? Okay, what can I do after this? So this was the Bolton's model that we use in medical education for all the undergraduates for education of reflective experience, which is self-experienced. But what we found when we showed a movie to our students and we asked, what was this movie about? So for example, I'll take Tare Zameen Par for, so they kept on telling that the acting was like this, Amir Khan was so genuine. What we wanted to teach him is how is dyslexia missed and how people are blamed, how it affects a child. But that message was getting lost. So what the kids or students were seeing it as a different perspective. So it was quite vague, and it is as long as chasing a wild goose without the intention meeting our intention. So what we thought was, this cannot go ahead like this. So if we are using movie as education, it should be structured and proper. Even though we reviewed many movies that have been reviewed and published, most of them are unstructured and re-narration of the plot with an author's interpretation of what that scene means to them. So we went ahead and we saw what about other scientific literature. We have extensive journal presentation. I think most of us are presented, attended, and we all have daily go through the journal presentation, which has been scientifically reviewed in a proper format, from title to conclusion to reference. We analyze them in a systematic manner. So if that serves an educational tool, if the people or students are learning from this journal presentation, this has to extend to all the scientific academic activities that we are doing. So what we thought was, let us see what is there for movie, but we do not have anything that for an art framework where we can review. Then we thought there is some objectivity needed and there is a structure needed. So we have to review in art with an educational value, but with a psychiatric lens. So hence we came up with this framework that we have developed in our department to review art form, more specifically a movie. So how did we develop this framework? So we went through a lot of literature review. We did about the general movies reviewed by the public. So after movie, a lot of people put movie reviews on what aspects they are focusing on. So mainly they focus on cinematic experience like acting, direction, music and all. So we did an extensive review of this. Second, we went and did an extensive review of how scientific literature is reviewed. For example, a journal, how is it reviewed? A book, a psychiatry themed book, how is it reviewed? So we went through that, how the reviews are written about this. And third thing, we also went and read various articles that have an interface with psychiatry and movies. I think many of us, the previous speaker has already shown us, and we had some of the speakers or the authors are here today. So the extensive and very nice articles that we found, how interface happens between psychiatry and movie. So we did such an extensive literature review. We drawn all the concepts and thematic points from this, and when we segregated them into different groups which they belong to. So, and then we had an expert opinion about this segregation of concepts, and then we developed a model and we put this model to a test. So this is how we developed this current framework, which I'm going to present to you all here. So our framework has total of 8 sections. So it starts from general overview. Second is cinematic review, social perspective, scientific accuracy, treatment portrayal, rights, message, and social impact. So some of them have subsections, and the responses are some of them required to put are questions which sentences or paragraphs are supposed to be answered, or some are them just like yes or no or nominal sort of answers. So coming with general overview, there is this is a heading, and there are certain points on what they can review the movie overall. So one is the title. So whenever we see a movie, we always focus on the title and communicate about the title. So that makes us movie whether to see this or not see. So with this title, there are so many movies with wrong titles. So you just can see how the title can be incriminating and inflammatory to see that the psychiatrist has been portrayed in this movie. So Shock Corridor, Devil Man's Chair, Madman, even our own movie like Mental Hai Kya. So they bring quite judgmental approach. So a student or a reviewer can comment on the title, how the title was appropriate and inappropriate. Second thing is mental health theme that has been depicted in this movie. Is it about depression? Is it about interpersonal relationships? Whatever it is, they can comment openly in a subjective manner of what theme that movie depicted. Even multiple themes are portrayed in this movie sometimes. Then they can give a brief note on plot. How was the plot? They can narrate the plot or briefly summarize it, and also comment about narration. So narration, how was the movie? Like, for example, it was very slow, it was too fast, it was just jumbled up, we cannot make sense of this narration. So they can comment on the narration of the movie. The next point is they are very given a chance to opine about what are their personal good and bad aspects of this movie. So we felt this aspect as good and this aspect was poor, so they can comment in a subjective manner. So these have been the first general overview. Then the second thing is cinematic experience. As we all know, what is a cinematic experience that generally people feel about acting. The acting was good, about all the actors they felt. Music, how was the background score, how was the songs. So I go to quote George Lucas, who is an American producer, who says 50% of entertainment comes from music. So without music, if you watch a movie, it is just like a plain and bland sort of food. So the music really contributes to a horror feeling or an empathy or whatever emotions that can be generated in a movie. Then cinematography, what angle was used, what was the scene construction, how was the lighting of the scene, whether it is poorly lit scene, that all gives an impact of the movie. And comes to the last is screenplay and direction under cinematic review, which obviously cannot be understated. It has quite an impact of how a movie performs. Then we went to social perspective. How is social perspectives being depicted in the movie? There are total six subsections in this section. We start with the stigma. So majority of our illness are stigmatized. So what is the point that how can we analyze this stigma? So stigma can be graded under following sections, that whether a movie in the movie the patient or a mentally ill person has been depicted as dangerous or aggressive. So this is quite common. The patient are posed as dangerous. They can be thought of, they're unpredictable. They can attack anyone at any time. So is there any sort of such portrayal in the movie that a reviewer can make a point about? Second aspect in this is whether the movie shows the person is antisocial. So we often get to see the movies which have been made by psycho killers, mass murderers, are obviously psychiatric patients. They have to show this. Otherwise, the audience will not, it may not appeal to the audience. So to just make your point, you are making a psychiatric ill patient as antisocial. This is totally not called for. So this is what we want to say, that we have to see it. You have to identify it. So if you show a movie in this direction, then a reviewer can put a comment that it is not appropriate. This is not what happens in real life. So whether the movie is unnecessarily or intentionally ostracizing the psychiatric patients. So these all points have been depicted in this movie. A reviewer can make a point on. So next point is stereotyping. So stereotyping, whether a movie has been, psychiatric patient has been cast in a particular role. For example, a patient can be cast as weird and eccentric. So they are either shown as child-like, or they can shown criminal-like, or they can shown as zombie-like of picture. Also, they can be shown as a victim. So they are victim of society. They are the victim of somebody's bad behavior. So they can also be portrayed as victims. So stereotyping of patient in such a manner. They can also stereotype it about mental health establishment. So mental health establishment have been portrayed as horror houses, prisons, or harsh environment. Okay, so this continues with the doctor portrayal as well. The doctors are portrayed usually as the authoritative figure or even as antagonist to the main role. So is the movie portraying in any of this manner? So reviewer can give a input about what they feel about this. So coming to third point is misconceptions. Whether the movie accentuate or reconfirm the misconception that are already existing in the society. So etiological misconception, we all know that various of our patients come with a lot of etiological misconception, such as the illness is caused by black magic, it is caused by curse, it is caused by so and so forth. It's what etiological misconception, or superstitions, for example. So the stress causes all the mental illness. Stress is an important factor, but it is not the cause for all the mental illness. So you don't worry, don't take stress, you will be all right. So making patient responsible for his own illness, and also that herbal medicines are good, all our medications are bad, such sort of misconception can also be portrayed in the movie. So coming to the next aspects in this is medical ethics. So what are the medical ethics that has been portrayed in the movie? So boundary violations, very important, which most of the movie disregard. So there is lot of counter transfer and transfer that is happening in the movie, which seldom happens in real life. Obviously, many of our patients and doctors have a romantic relationship in the movies, which seldom happens in real life. So this is what the reviewer has to observe this, and has to put a comment and criticize the movie. This is wrong, that it should not be portrayed in such a manner which does not reflect in real life. It can also have various other violations like confidentiality issues and consent issues. In real life, nothing happens without confidentiality and consent. We do hardly any procedures without confidentiality thing or taking consent, but hardly a point for movie makers to focus on. Next comes is a social, in the social perspectives, caregivers perspectives. So what do they show about caregivers? Do they show about the burden that caregiver is going through? Do they show about the emotions that they are experiencing, including expressed emotions, or do they have a struggle? So whether the reviewer can focus on what are the other aspects of the movie, that emotional aspects of the movie that has been portrayed. Coming to last section in the social perspective, that is substance use. Substance use is quite common being portrayed in the movie, and in almost all the time in a wrong way. So they can normalize the substance use as a heroine doing, or a hero doing it. So it is just okay, anyone can do this and everyone does this. So does this normalize the substance use? And also, does it glamorize the substance use? For example, in a movie they can show the hero can only propose to a girl when he is under intoxication, or he can commit such a grave act or a heroic act only under intoxication. So unnecessary glamorization of substance use can also be portrayed, which has to be pointed out and brought to notice. Coming to fourth point in our movie review is scientific accuracy. So this is also called as verisimilitude. It accounts for all the art that has been shown with some scientific or realistic touch. So what does this movie shows? Anything related to dementia, for example, if they are portraying dementia in this movie, is it anywhere scientifically accurate? Is the symptoms are of dementia, or they're just showing something else? They may make all the child psychiatry illness as childish. So the psychiatry patients are not all childish. So they may some sort of portray it in an unscientific or unrealistic manner that rarely happens. So next aspect is, how is the treatment portrayed in the movie? So what comes to our mind is, first is competence. So is the movie showing psychiatric treatment as competent or ineffective? Are they saying that treatment is worthless, it is useless, or do they have any effect on the patient? Second thing, that is promotion of unscientific treatment. So most of the movies do promote magic, love, or some other heroic acts as a treatment. So any proposition or confirming such unscientific treatment as actual treatment for mental illness. And the third is unnecessary using the treatment as punishment or criminalization of the treatment. We all know that, I think most of us has watched this movie, One Flew Over Cuckoo's Nest, unnecessarily criminalizes ECTs. So is there anything that has been portrayed in this movie about treatment and put treatment in a bad light? The sixth point, what we want to put say is human rights per se, and human rights especially, that is the movie show that anything against human rights things that are happening. So how often do we chain our patients like this? None as of now. In the last 20-30 years we have never seen, but movies even made today show this. Why is that? So there are basic violations. They are being denied food, they are being denied freedom, they are being denied basic amenities as a part of a psychiatric treatment, which is very wrong. We don't do it. Then why is movie saying this we do it? So this is wrong. There are also violations of Persons with Disability Act. according to them. There are certain rights. For example, they have right to equality and non-discrimination. They have right to access to healthcare. They have right to employment and community and family, which is not being should not be tampered with whenever we don't do it. So it should not be done in the movie as well. So if the movie is depicting any of this sort, the reviewer can put a note on this aspect. Ultimately, what is a movie giving a message to the viewers? So this is what we want to say. So what does a movie give review? Does it invoke a compassion in the general public that, okay, with compassion the patient might better? That's a good thing. If the movie develops curiosity about a certain illness, okay, yes, this movie we want to know what is this illness about. So does the movie also say about something about hope, that something good thing happens, so something they end it the movie in a positive note? Or they also unnecessarily bring a nihilism in this movie, that nothing can be happened, nothing can change, that it's all going in vain. So any of this sort of message what they want to give to the audience through this movie. And coming to last section, what is the social impact of this movie? How do we assess social impact? One is commercial success of the movie, how far and wide it has reached. So it is commercial success, that how much money it has made, so it has appealed to the mass audience. And also they can go through the reviews of the general public, they can read what other people are feeling about it, and also see that whether it has changed in any social perspectives. Okay, we have seen some of them coming up after a movie released, that coming up with some certain symptoms, like I think I watched this movie and I think I have certain disease like this, OCD. So they come up with, I may be having OCD. So this is increasing the perception about, social perception about the illness. So they are coming to for treatment. It can also happen in patients may increase in number of suicide after seeing such a, we all know that Sierra movie had lot of dramatic thing in the theater about the audience. So we know how it can influence people. So also acceptance, we obviously get a movie that after Brother Nikhil got released, many of the people came and seek our help regarding acceptance of their the orientation and their gender preferences. So such thing can also have an impact, whether this movie is having an impact on the general audience. A reviewer can go through social media posts or go through the blogs and read what this movie has caused in the society, and give a view on his view on this social impact of this movie. To summarize, these are the 8 points that we have made: general overview, cinematic perspective, social perspective, which has 6 sections: stigma, stereotype, misconception, ethics, caregiver's view, and drug abuse; scientific accuracy, treatment portrayal, rights of a person, message the movie gives, and social impact the movie has. With this, I conclude my second presentation, and we have made, we tested our framework with, we have been doing movie reviews for quite long, and we have, with this movie review, we have summarized the findings, and actually the third person who was supposed to be is not there, so we will be covering up his topic as well. I invite Madam for continuing her session.
Thank you, sir. So just now you gone through the model which we have developed for the movie review, and then to test this model, we use this model with our in our department, and asked the residents to review the model. So we went to select the model. We reviewed total of 22 movies, and most of them were regional movies, because we know that most of these regional movies, they penetrate deeper into the society, and the common people are the ones who will be watching these movies. So we wanted to understand that how these movies have been, what they have depicted about the psychiatry and the conditions about it. So we asked, with the help of residents, we were able to review around 22 movies, and most of them are in Kannada, and few movies are in Tamil and Malayalam. So with the model, the themes what we found is majority of the movies were on psychosis, followed by dissociative disorders, and also other disorders were included like depression, childhood disorders, multiple themes, movies having multiple themes, and also few movies also depicted on OCD, insomnia, gender dysphoria, dementia, and traumatic disorders. As per the model, the first one is about the title. Most of the reviewers found that the title was appropriate, and few of them still found that it was not very appropriate. And about the cinematic review, most of the reviewers found that the acting performed in these movies were fairly better. whereas regarding the music and cinematography, it was moderately done. And whereas the screenplay and the direction, it was found that it was fairly better. So about the stigma, it was we have another two things which will be followed by so.
Okay, so this is what we found out. There is a uniform distribution about stigma in all the movies. So some of them were very high stigma, some of them had high, moderate, somewhat stigma, and none. So the equal distribution in all of them. And there is a stereotyping. Most of the majority of the movie did not have stereotyping as a single section, but there are almost more than 50% of the movies portrayed a patient, hospital, or a doctor in a stereotypical manner. The next is misconceptions. If you see, there is none in majority, but there are movies which also had some reinforced misconception, almost nearly 50%. Ethics violation is more than 50%. Most of the movies, though we're not surprised, it is not all, but most of the movies do ethics violation in different intensities. Caregiver's perspective was shown in majority of the movies, though some minor amount of movies did not focus on caregivers' perspectives. Glamorization of drug use was found in only minuscule of the movies, though our movies were not of the one which we selected of drug abuse sort of. These were other movies. None of them were substance use movies, but in our review also, some of them did have a glamorization of drugs. So scientific accuracy, when we go through, there were hardly few on both the extremes, either accurate scientifically or totally bad in scientific accuracy. Majority fell in the midway. So somewhat poor to fair to good scientific accuracy, that what the symptoms they have portrayed. Most of the producers and directors have no knowledge of psychiatry movies. They do not go through any scientific books, or what they gain knowledge is from their previous movie somebody has directed or made. So they take that as a gold mark and standardized symptom portrayal, and they portray it in the next movies. So majority of them are very poor in this manner as well. So competency of treatment, you can see that green is very effective treatment is very small, because if they show the treatment as effective, they have nothing else to show in the movie probably. So that's why they do this. But there is cinematic liberty, but they cannot downsize or defame treatment for any manner. So there were a lot of movies that showed that treatment was ineffective. So if we go through misuse of treatment, majority of the movies did not portray the treatment has been misused, but though one fourth of the movies, almost a quarter of movies, showed that treatment has been misused as a part of their movie. Promotion of unscientific methods is almost in half of the movies that has been portrayed. They promote some or the other unscientific method of treatment. Rights violation, though not much, but definitely a point. Majority where did not violate any rights, but still some of them did. So this is what our reviewers felt after reviewing all these 22 movies. So social impact, it is almost like equal. So some of them had very good impact, some of them moderate impact, and some of the movies did not have any impact as per our reviewers. So with this, we conclude our movie review framework. There are certain limitations that we want to put forth in this the forum. Even with all this objectivity that we try to bring in, some subjectivity persists. We cannot totally make it objective. Some feeling, personal experiences, they still creep in. Some personal biases may still creep in this. Okay, and there might be little overlap of concepts here and there. So though we did an extensive segregation, but we have not done a statistically segregation. We have done a conceptual segregation along with the expert review. So there might be still some overlaps between what is stereotypy, what is misconception, and what is stigma. So on like this, there can be still some overlap of concepts. Some reviewers may find it a little restrictive to see it in this manner and to report in this manner only. So they want more liberty to review, and they might feel these points or this categorization a little more restrictive. And lastly, there is a phenomena called as Bader-Meinhof phenomena. What does this suggest is, if we introduce public to a concept, and if they learn this concept as a new concept, there's more chance of them seeing this in the subsequent interactions. So if we orient them to stigma, so there is a more chance of they start seeing stigma in all the future movies they see. So there is a frequency bias that can creep in. So that can under limitation that we want to put it. So that is Yeah, we are finishing. One last slide. So, yeah. Yes, I'm finishing. This is the last slide. So, in conclusion, what we want to say is movies can serve as an effective tool in education that we all know of as of now. Cinema education can be incorporated as a regular teaching method that we are already doing, and we appeal the more number of institutions to take cinema education as a part of regular teaching program. But doing it without reflection, doing it without a proper framework does not meet the goal. So we want to, there was strong felt need that there should be a framework how a movie should be reviewed, and hence that we want to fill this gap with this model or with our framework. And that's what I bring you to you today on this platform. I thank the organizers. I thank Dr. Pavitra Madam for giving us a platform, and Dr. Asta for making us, and all the chairperson, Dr. Darpan Madam and Raghuram sir. Thank you all, everyone.
Both of you have, three of you have conducted. One could not join, but it is very well presented, very artistically depicted, scientifically grounded, very suited to the theme of psychiatrica. And I think we were supposed to do this session yesterday, but because today it is happening today. And I was very happy to see one of the present on Mirror Mirror on the Wall. So I write poetry in the handle of Mirror Poet. Yes. So that's the next one, Mirror Mirror on the Wall. Okay, so I look forward to that also. And I feel that if the audience, it's a very interesting topic that you have covered. So if anyone from the audience wants to give any comment or ask any question to them, yes sir, please introduce yourself and come to the mic. Yes.
Good morning. Thank you very much for the wonderful presentation. And I would like to know two things. There are two questions. The first question is, I have seen what came to my mind is about the subjectivity, the variables which you pointed out. It's very subjective. So can it be made a little bit more objective, like glorification of drug use by certain scenes or certain frameworks which have been used in the movie? Can it be used as a variable or an index, so that like a little bit quantification can be made in the approach? This is my first question. Can it be made, or whether it can be? And the second question is, can cinema or movie be applied as a therapeutic measure, like art therapy, like visual art therapy or music therapy or drama therapy or something like that, or poetry? Can cinema be used as a therapy to invoke certain changes in a psychopathology? Thank you.
Thank you, sir. That's very interesting take. Actually, I want to answer the first question, the subjectivity. Okay. Actually, there was a comment about subjectivity here. Was if you make it too objective, that the component of art, creativity, and expression goes off. So you just make it a scale wise, yes, no, or 1 to 5, so that the freedom of expression goes off. So that can be one take, that whether to make it completely objective or not. And I, in one of our reviewers gave that these questions are, we could not present them this framework as it is, so we framed the questions on this basis. So if you want to make title, you either mark it as appropriate, inappropriate, or I'm unable to comment. So if you give they would write a few paragraph about the title, so we cannot anyway summarize that and do an analysis about it. So we made some questions, and they still felt that okay, this is too restrictive. That's what I put, one of the limitation. So you cannot make us just write appropriate in, or I want to say more about this. I want to say it is like this, like that, like that. So that is one point that might bring a little, if you try to make it more objective. But anyway, that objectivity is required. That we still want to convey the proper message and what we want to do. So we can definitely make it more objective. This framework what we have done is developed in a single institute and applied in a single set of environment. This can be taken to other institutes. This can be done with a wider critical analysis of this. More statistics can be applied to this, and that can be made as objective as possible, with still a tint of subjectivity has to persist, especially when it comes to art. coming to your second question, sir, movies being shown as a therapy. Do we have such movies which can act as therapies? There are documentaries. Yes. How interested will a person be to watch a documentary? Definitely, sir. There could be different takes on commercial movies. How scientific accurate they are. Do they actually portray what we are doing in our? Does the therapist go on a cycle ride with the patient? Does he involve in all the other behavior that he does? So there might be different sort of scientifically accuracy might change.
Can a study be made like this? As for example, I can mention another movie like Sound of Music. We all know about Sound of Music.
Yeah.
So it creates a sense of wellness or a sense of happiness within us. Whenever we see Sound of Music, sometimes more than once. Sometimes even it is more than 10 times. There are movies like that. So can we use that as an artistic
Therapeutic
tool? Since this is a psychiatric and this is the interface to talk about, can we use cinema as a therapy?
Sir, there is no inhibitions
Thank
to
you
not
very
use.
much. We have the next
Yeah.
presenter waiting. Madam, you want to make a comment? Quick comment?
Yes, I would just like to reply to what
Yes, please introduce
because,
yourself.
I am taking part in the symposia after this, and I am a filmmaker, and I
Oh, very
make films
nice.
especially for mental health. And to answer this question, I try to make the film as interesting as possible, as cinematic as possible, to get the message across without the stigma. And the latest film which I made is an animation film for children to go and see their counselors, which is doing excellently in all schools. And it's very interesting, children are enjoying it. So it is possible to do all this. And I'm so glad that people, because I face a lot of problems from everyone, from the audience, from psychiatrists, who wouldn't use cinema as a medium, when especially in places like India and other cultural countries, the cinema is a huge medium. So now, WPA, psychiatric, everybody is, encouraging this. So it's a wonderful sign. I would love to collaborate with you. I came
Thank you,
especially to see that,
Thank you,
so
ma'am.
that-
Thank
and,
you, ma'am.
See, like you're saying, people are, they want to see, but my film is going to run documentary, I think one after this. But there's no audience for it. So we need to promote all this, so that.
Thank you.
Just to answer his question in one sentence, sir, we can attest a movie which has been done by a documentary or commercial movie. We can certify like this can be watched over for patients. Only certain movies can be shown to patient as a therapy and not indiscreetly. That's what final answer I want. Thank you.
Thank you. It was very interesting, both the papers. And maybe the discussion can continue.
Okay, so we invite, I think, Miss Dr. Angel from Nepal. So she is going to be the next symposia presenter. And so we welcome you to India. And are your slides? Graphica, a psychiatrist's perspective. Yes.
Thank you very much, ma'am. Good afternoon, everyone, and namaste to everyone. This is me, Dr. Angela Rigmi, all the way from Nepal.
Adjust
here.
the mic for your voice.
Okay.
Yes.
Myself, Dr. Angela Rigmi, all the way from Nepal, and I'm consultant psychiatrist and currently working on Hopeful Horizons, Nepal, that is located in Kathmandu, and I'm also honored to say that I'm the only New Graphica art specialist in Nepal, and I'm thrilled to be here and be part of this Psychiatrica symposium, and to be here among the art enthusiasts, creative enthusiasts, psychiatrists, psychologists from all over the world. And since I'm also an art enthusiast, and where passion meets psychiatry, New Graphica was another field for me that was a new endeavor. So I discovered Neurographica just a year back, and I decided to take this course, and I think it was a great endeavor for me as well. So today I'm going to share the Neurographica perspectives from a psychiatric point of view. So what is Neurographica? Neurographica is patent to Dr. Pavel Piskarev, who is a Russian psychologist, and it is a very new concept and very much recognized in Western part of the world, but it is still not known in this part of our world. Neurographica was just founded in 2014. Neuro representing neural circuitries, and graphica means visual drawings. And this term, neurographica, emphasizes the role of drawing and its influence in the neural pathways. So that is what neurographica is all about. And the core idea is that we can transform our inner conflicts, we can transform our emotions into the paper and draw it and then integrate it into something meaningful. And this can be taken as a tool for healing. This can be taken as a tool to change our perceptions. So that is all neurographica is all about. It is a structured drawing that uses lines, roundings, shapes, and it is also an expressive kind of technique. So before going into the depth of neurographica, I would like to talk about some of the principles, and it's quite interesting because it starts with the fact that universe lies in the tip of the marker. Pavel Piskarev, the founder, especially has seen this because he believes that everything in the world can be represented in the form of lines and circles. And even our problems can be represented in the paper in the form of lines and circles, so as the solution. So he especially sees that image integrates meanings, and meaning represents state of mind. So when we have this state of mind represented in the form of lines and circles in the paper, we have this tool in our hand which we can use to modify, to integrate some other meanings and turn it into something beautiful, something aesthetically pleasing, and turn it something colorful, turn it into something beautiful and give new meaning to it. So neurographica is actually a combination of philosophy, it is a combination of management, it is a combination of science and art. So here we basically discharge the emotion or a problem in a paper and bring about the solution by drawing, simply by drawing. But we have to keep in mind that neurographica is not a diagnostic tool, and it is not a replacement for therapy or medication, and it is not yet an evidence-based neuroscience scientific method because it was just founded years back. But it's still an interesting field of science because as we know that art therapy has already been established by science as evidence-based practice. So neurographica incorporates all those researches that explains that art is quite beneficial. That's why neurographica works clinically, because it combines the principle of psychology, especially the Gestalt theory, and I'm going to talk about that in later slides. It combines visual communications, it combines psychology, and Pavel Piskarev has tactfully incorporated drawing with cognitive behavior therapy. And thereabout, this drawing methods can be used for behavioral activation, for cognitive reframing, for emotional regulation, and can be used for mindfulness, can be used for grounding techniques, and it can be also used for non-verbal emotional expression. And he also has added the insight that non-verbal expressions are quite useful for exploring the deeper part of unconscious mind, because non-verbal expressions are quite easier than that of verbal expressions for some of the patients and some of the clients. So he designed this method which incorporates the evidence of art therapy and then evidence that comes along with cognitive behavior therapy, and tactfully has combined both of these to bring about neurographica as a newer technique. So talking about the neural circuitry that is involved in neurographica, I'd like to highlight the neural circuitry in art therapy. Like, we know that as a psychiatric, those who are from psychiatric background, we know that while drawing, we activate the prefrontal cortex, that is especially for focusing. And then we activate this corticothalamic striatal loop, that is for planning, sequencing, and reward-like feeling. And then there is activation of prefrontal cortex, especially that brings about activation of top-down loop. So as this top-down process activates, the emotion is overpowered. And then we can switch the task, and then we can focus more into the solution-oriented part of the brain than that of emotionally overwhelming or overpowering lower part of the brain. As well as the activation of prefrontal cortex, there is also activation of both hemispheres of the brain, just as in EMDR that we use in PTSD, by bilateral simultaneous activation of the brain. We use left part of the brain for logical stimulation and for also drawing the structures and for logic and for numbers. And on the other side, we use the right part of the brain to activate emotion and intuition. Beside this, I would like to talk about dorsomedial prefrontal cortex, and specifically, I would like to talk about the default mode network that is most meaningful in terms of art. Because, you know, as default mode network, we know it's activated in default state, like in rest state. But whenever we look at the art, this DMN, default mode network, gets activated. The suppression is released. And that's when our brain starts imagination. And imagination most of the time incorporates introspection, the focus that is drawn inwards. So as I said earlier, there's activation of the prefrontal cortex that is for the focusing in the external part of the world, in the drawing, in the paper, and the activation of DMN for internal focus. That is also helpful for sense making. Like, for example, when we look at the drawing, our brain has this innate need to make sense of the drawing or artwork that we look at. So when we look at the art, we have to make some meaning out of that. So DMN is activated to bring about the meaningful interpretation of the drawing. And that's where the phenomenological aspect of aesthetical intelligence comes along. So as I said, aesthetic intelligence, this is a new aspect of neuroscience and new aspect of research where we deal with perception of the drawing, where we'll deal with appreciation and creativity. So DMN is involved in imagination, it is involved in creativity, and it is also involved in creating new meanings into the drawing. So while we draw, there is activation of prefrontal cortex, default mode network, and the executive network, as well as different other parts of the brain, simultaneous activation of two hemispheres. So by this way, there is activation of top-down process. So emotion is overpowered. By this way, we do emotional regulation, as well as we can incorporate the techniques of cognitive behavior therapy to bring about the cognitive reframing. So Pavel Piskarev has tactfully incorporated both these aspects of CBT, art therapy, into Neurographica. So specifically talking about the conceptual aspects of Neurographica and how it works, here we use the neurographic lines. Like you can see these lines that are going along the paper in any direction. And there is one principle of Neurographica which says that drawing has no boundaries. So, you know, you are free to draw anywhere in any part of the paper, and anybody can draw lines and circles starting from 2 years of age. So in that aspect, we can say that drawing is easy. And we do rounding. Rounding is for emotional soothing. Here we incorporate the Gestalt theory, which is more related with looking at the picture as a whole. So in this Neurographica, what we do is we round the intersecting lines and turn these sharp edges into round pictures, which resembles the part of a circle. So it is more like a incorporation of as a whole Gestalt theory. And then we connect shapes and give meanings to the particular shapes. And by following these lines, techniques, and different algorithms, we bring about different patterns of drawings. As an example, I have shown here some of the drawings that Neurographica, that follow some of the algorithms of Neurographica, and this one is Neurotree. And this is the one that I drew during my portfolio. This represents the past, present, and future. And it incorporates the aspiration aspects of cognitive behavior therapy, and also incorporates the aspiration prioritizations, and also future manifestation that is also incorporated in Neurotree algorithm of Neurographica. And this is the another model, that is the algorithm for relieving limitation, that is drawn for reducing anxiety. And this is the another example of model, that is the score model that we use for problem solving. And this is another model that is done by the techniques of Neurographica. And this is Neuroikigai, and this is for self-actualization. So, believe me that, trust me when I say that we are just following few algorithms, and we're just using lines and circles and few number of colors to draw this. So this shows that creativity and mental health are a long journey, and creativity inversely is related to anxiety, and we know that activation of different part of the brain does help us understand the role of creativity and emotional healing and mental well-being as well. So, talking about the scientific limitation of this Neurographica art technique is that it has very limited peer-reviewed data, because it is quite new, established just in 2014, and has mostly anecdotal evidences, and takes about the evidences from art therapy and cognitive behavior therapy itself. So we have long way to go in the field of Neurographica, and needs further clinical trial as well. But talking about the strength, it is accessible, it is non-threatening, and it is a very good option for those who are art enthusiasts and those who have got affinity towards creativity. And it is excellent for group therapy, enhances introspection and relaxation. As I said, the role of DNM for introspection, so it also enhances creativity. So in conclusion, I would like to say that it is a bridge between rational and intuitive method, a structured path to emotional clarity. At last, I'd like to say that something about this picture. You can see I have used some of the highlighters to draw this drawing, and some of the markers, and we simply follow lines and circles, and this includes the last principle of Neurographica, that drawing is easy, because believe me, we just use 2 or 3 highlighters and markers to make it. So definitely creative outlook, this kind of creative outlook is worth giving a try. Thank you so much.
It was a very interesting presentation. I think you highlighted some of the stress reducing aspects of line drawing. That's what they stress in mandala art, and what they call a Zentangle. So where they use the lines and forms to reduce mental stress and improve concentration. So I think it's an interesting aspect, and I'm sure there'll be some questions from the audience.
So in that thing, I want to add that there is also another algorithm called as Neuromandala, where we use mandala, but they are basically using different forms of art, and using the same, based on the same principle, that 7 principle that I showed earlier, and use different aspects like neurosnow, neuromandala, and neuro rain. So there are other algorithms as well. So it's quite interesting for those who are interested in art and creativity.
Very nice presentation, very confident.
Thank you, ma'am.
And very composed and very calm, and like art you're presenting. And I'm sure people listening,
or confidence within themselves to bring up, to explore creativity and art. So that is a good option for those who are who have that affinity towards art. And earlier in the session of dance and movement therapy, as the clinical psychologist said, those who are interested, it is there are one group of people, different group of people who have this affinity towards art, and it's completely the patient's or the client's choice which modality they want to choose. So it's up to them. But having said that, it's good for anxiety and also for trauma, because in some of the algorithms we also explore the past experiences and traumatic experiences, so we can use that in individual sessions as well.
So I think my thoughts are two thoughts.
Yes,
See,
ma'am.
every brain is very unique.
Yes,
Every
ma'am.
human brain
Yes, ma'am.
is unique. So when a person is drawing, what of they are like they're projecting it in their
Yes,
drawing,
ma'am.
and they are making a unique
Yes, ma'am.
thing for themselves. So as you said, it's good for anxiety and trauma, but also you can think of patients who recovered from schizophrenia or OCD or severe depression, bipolar, addictions. So a lot of centers integrate art therapy in
Yes.
the psychosocial rehabilitation programs. So what you can maybe improvise and think in your country, that this specific art form, there's a lot of art therapy
ma'am.
which should be done, but this specific art form, maybe you can develop some research or something and take it to a next level by making groups of patients or with certain conditions or in certain phases, but not in the acute phase, but when they are recovering or recovered, where any uniqueness of this art form can be helpful to any subset of patients or all patients, and in what process can the art therapy be integrated. So sometimes some people also in the acute phase, like if they have bipolar affective disorder and bipolar depression, or in even unipolar depression, and in the acute phase, some people already have used art in their childhood, or they like art, they might use art for as their own coping
Yes,
or
ma'am.
self therapeutic ways to cope with their distress. It's an excellent model to work upon and integrate it in different mental health problems as well as psychiatric disorders. And group therapy is what you are currently doing,
Yes, ma'am.
but you can also improvise and work with small subset individually to see how individual expressions and study them very nicely, like
Yes, ma'am.
in depth, and to see what are the variations. So even if you have say 10 patients of 10 different psychiatric disorders, one of person who's recovered from OCD, from BPAD, from addictions, and see how this art form and how individually it will manifest, and how what will be, and then maybe once their art is done, have a session with them to kind of know whether it has been therapeutic or how they interpret
Yes,
that
ma'am.
art. So these are some areas in future you can
Yes.
grow upon with your work in art.
Yes,
Okay,
ma'am. Thank you so much. Thank you so
Yes.
much, ma'am.
I just want to add one thing that you told about the psychopathology. So the drawing a person or drawing a tree, drawing a house, all these have been used to find out about the psychopathology or organic change in the mind. So drawing is an expression of the brain, especially the frontal and prefrontal brain. So we can definitely work in that direction.
Yes, sir. Thank
One
you.
more suggestion I'd like to give you. There are some studies which, if you have facilities at any institution for neuroimaging or PET, so while they're doing the art, like there are some studies in America when people are composing poetry or writing songs, what are the brain changes happening. So those are some novel ideas.
Yes.
But in future, if you want to take this area as your own niche, there's a lot more good work you can do. We leave to the audience if they'd like to ask any question or any comment. For please introduce yourself and come on the mic. You would like to use the mic? Yes. Okay, thank you. Don't drop the mic.
Okay. Thank you so much for the question. And it's quite interesting question as well. In my practice, I used this technique to neurotic patient mostly. And because it's quite beginning of my practice, I didn't do it with the psychotic patient, and obviously there would be this issue of compliance and stuff like that. So we used it to anxiety patients, and I've also used it to depressive patient, as ma'am mentioned earlier. But in Neurographica, what we say is one of the principle is subject is more important than that of the object. So the drawing actually does not matter, and how the patient feels after doing the drawing is more important than that of what is the outcome. So in that way, we have been conducting this pre and post test before doing the drawing and after doing the drawing, and we assess the level of anxiety or level of stress they experience before and after the drawing. So there has been significant reduction in anxiety as such. So most of the population is neurotic only. And regarding the second question, why, what was the question like? Okay, so we have used limited color because we don't want make, because coming to the, to make the drawing or the outcome aesthetically pleasing at the end. Okay, to bring about that sense of aesthetic sense, and to bring to make the drawing more close to the person subject, we want the drawing at the end to be more aesthetically pleasing. So it is said that we are only using 4 or 5 limited colors so as to make drawing little less chaotic. But it's up to the patient, or it's up to the client, whichever color they want to use, whichever number of color they want to use, whatever they want to do. So at the end of the day, how the patient feels or how the client feels is more important rather than the technique. So that's the main fundamental thing that we do here. No, as a specialist, I have that techniques to follow as a specialist. But when I'm doing it with the client, it is like do as I do, but the rules are for you, me only, and the subject should feel better at the end of the therapy. So my concern would be making the patient feel better, reduce the level of stress, do grounding and therapy, and drawing is not much important than that of the patient's subjective feeling. That's it. Okay.
Any other comments in relation to this?
So with this, we will conclude your presentation.
Okay. Thank you so much.
Thank you very much. It was a very nice presentation. And thank you. We welcome the third Symposia presenter, Dr. D. Through a creative and cultural lens. The presenters are Dr. Joel Johns, Dr. Vibha KV, Dr. Shaili S. Singh, Dr. Neha Karan J. from the Department of Psychiatry, St. John's Medical College, Bengaluru. And we have with us Dr. Vibha KV.
Dr. Jewel.
Who's
Dr. Jewel Johns.
Okay,
Yes.
Dr. Jewel Johns will be presenting. I think the organizer had informed us that Dr. Vibha is here. So sorry. Both of you will be presenting?
All four
All four will be presenting. Okay, so the first presenter for this is Dr. Joel Johns, and we'd like to tell you that you have about half an hour's time for this presentation, and 1 o'clock the next group will be here. So go ahead with your presentation, and sorry for the confusion. We welcome you, Dr. Joel Johns, to begin your presentation. Thank you.
Mirror, mirror on the wall. Who defines beauty after all? When the first light broke across the world, so began humanity's search for beauty. Good morning, fellow wayfarers. Join me as we travel across centuries to unravel how beauty ideals changed and evolved, and how media has reflected and reshaped them. But to truly understand what we call beauty today, we should look back. Let's step back into the earliest chapters of human history, where beauty wasn't curated by camera, but carved in stone. So when we look at the prehistoric to ancient ideals, there was the Venus of Wildendorf. Beauty for a woman was emphasized by large breast, stomach, as well as hips. Fertility is what mattered during those times. Then, if we move on to Doryphoros, he was created by Polykleitos, a sculptor where the whole model was a bronze model that focused on his lost treatise, the canon, that looked at proportion and symmetry. Then, back home in India, the then India, Tribhanga. Tribhanga means the three bends. The three bends were at the knee, the waist, and the shoulder, signifying rhythm and youth. And this was beauty back in those days. From survival and fertility symbols to idealized shapes of ancient empires, beauty kept shifting as time went on. Now let's move on to the Renaissance era, where balance, proportion, and human perfection was all the vogue. Here we look at Botticelli's Venus. Who hasn't seen this painting, right? It was about how she was flown ashore and then dressed by the nymphs. And this was beauty back then. Then came the golden ratio, something that we appreciate even today, all about proportions. The golden number, the divine proportion, Fibonacci ratio, you name it, we know it. 1.618 is the number that we look at. Then came classical beauty, accentuating the body in such a way that the female beauty was S-shaped. Can we really boil down beauty to a letter? But beauty changed again when the world moved from canvas to camera. Let's step into the 20th and 21st century, where films, advertisements, and social media started defining, editing, and maybe even amplifying beauty like never before. The 1910s had the buxom Gibson girls. 1920s brought the flapper girls, who pushed away all known ideals of feminine beauty and brought in short bobbed hair, a short hemline, and a fun attitude, where it was all about moving away from the ideals expected of women. Who doesn't know this woman from 1950s and this picture that is etched in humanity's mind almost? That's Marilyn Monroe. She brought in an era of weight gain pills. Can you believe that in 2025? Then came 1990s heroin chic, Kate Moss. This was the era where you could do drugs, you could smoke, you could do whatever you wanted if you could achieve this look. Now, when we talk about beauty ideals, there's a thought that it's only the women who are victimized. But, oh no, my friends, that's far from truth. When we talk about beauty ideals, the pressure was also building on men sharply. The 1930s and 1950s, there came the Hollywood icon look, where it was all about being swell, athletic, because they had to do their own stunts. And then was the birth of the Hollywood icons. 1960s pushed this boundary. It was about androgynous era. They grew out their hair, they were thinner, and they were expressing themselves. The era of self-expression. 1970s and 1990s brought the action figure. Almost unimaginable proportions, where you had to put in the work to look the way you do. 2000s brought the dad bod, where we looked at what beauty meant actually was just comfort. And so, as we see, with time changed beauty ideals even for the men. The new era of beauty, the era that we live in now, is to be pursued, created in sterile OTs by talented surgeons for the appreciation of the masses through social media. So this first trend is from TikTok, where an ideal beauty, a beautiful woman, would be somebody who can stack maximum number of coins on her collarbone. Who doesn't want that, right? Or do we actually think about this? Have you ever thought, today I want to look good for the conference? How many coins can I stack on my collarbone? But this is what our children are exposed to. The ideal waistline is supposed to be thinner than an A4 size sheet. In South Korea, the most common graduation present is a blepharoplasty. Imagine you graduating high school and your parents say it's time for your first surgery. Kim Kardashian, we know her. There is no need to introduce, she's the icon of the century now. And the body modifications, it's almost like when you change an outfit, now you can change your body. the men are also affected. They are going on to cuts. They eat, if you see this image that I've created using Canva AI, is just rice and chicken and rice day after day. And there's steroid injections, and that is Ollie London, very famous on social media, who changed he's actually a British national, who was trying to look like K-pop icon Jimin. Body dysmorphia disorder, current prevalence data, this is from US, looks at around 1.7 to 2.9%, and these are the people who sought help. And yet, beneath all these shifting trends, there's a surprising truth. Humans do share a broad consensus when it comes to elements of beauty. Facial symmetry, monotony, proportional average, and balance. But when I try to Google, what is the one common beauty ideal common to all? Any guesses? No, there is no common beauty ideal. Our perception adapts to see what we repeatedly see. Beauty now is the big business. And yet, guys, despite all this machinery, when it comes to what we like, beauty truly lies in the eyes of the beholder. The heart wants what it wants. Thank you.
Thank you.
Good afternoon, everyone. So continuing on to my colleague's excellent presentation. So I'll be talking about body dysmorphic disorder per se, and what is the role of creativity and vulnerability in body dysmorphic disorder. So before I begin, I just want to say one thing. Darpan ma'am has been, I have this connection with her. The first paper I presented as a PG, ma'am was the chairperson. Another ICAMCon, the symposium, ma'am was the chairperson, and now here we are again. So
and thank you that you chose my name as your symposium, as the symposium title. Darpan means a mirror, and I write poetry as mirror poet, and I've written one poetry on mirror on the wall, which is the best journey of them all. I'll share with you later. Yeah. But you look very familiar, so nice, Vibha, and continue your presentation. Thank you.
Thank you, ma'am. So coming to what are the biological vulnerabilities. So a lot of study has been done about how genetic vulnerability, like related to functioning of dopamine and 5-HT in the prefrontal and subcortical brain, can either lead to a creative ability or can lead to severe psychopathology as well. So the overlap between the two is quite significant. So what it leads to is a transient cognitive disinhibition, which can go either way, depending on people's other cognitive abilities. Either they can develop severe psychopathology, or they can have very good creative abilities as well. So this Venn diagram actually shows that what is the overlap between creativity and psychopathology. So the common elements, if you see, it's basically your attenuated latent inhibition and preference for novelty, and also hyperconnectivity. So this is the shared vulnerability between creativity and psychopathology, so which is also seen in and used for the management of body dysmorphic disorder as well. Coming to what are the personality traits we know in body dysmorphia. So one very commonly or frequently found trait is perfectionism. So people here basically are setting very high standards for themselves, being extremely critical of themselves, and so they notice even minor flaws and intensify the focus on these flaws, so which can lead to distress with inability to tolerate any kind of imperfection at all. So these kind of imperfections are not even noticed by many people, but because of these perfectionistic traits, they are more prone to observe them and also get distressed by them. So some of the study findings indicate they obtain higher scores for perfectionism than healthy controls, and also perfectionism was found to be a relevant predictor of dysmorphic concerns in a study done on university students as well. Other personality trait which is frequently studied and talked about is aesthetic sensitivity. So this aestheticality concept was given by Harris in 1982, which is similar to music ability. Basically, people are more prone to notice the beauty or the finer aspects, the nuances of external appearances. So what happens? They have a highly developed sense of aestheticality, so they're more self-conscious of abnormalities in their appearance as well, which can lead to a permanent feeling of irritation when they focus on these symptoms can lead to BDD as well. So in a study done on the BDD group showed distorted emotional or evaluative processing, but a high perceptual sensitivity. So they're more prone to notice these flaws, and also they're more distressed by this the tiny nuances of beauty or what they consider as beauty ideals or standards, and they get more distressed by it as well. Other very common personality trait what we see is behavioral inhibition system. So basically which regulates your aversive motivations. And in individuals with BDD, there is a greater personality impairment reflected in less initiative or inhibition of self-organization. So there is also higher values of harm avoidance, which is associated with BIS. So there has not been any direct study investigating the connection between the two, but which is something of interest. So why are we talking about all of this? Where are we going to use this? My colleague later will be talking about how you can use these vulnerabilities or these aspects of their personality in therapy, like how vulnerability can become a virtue as well. So some of the work done in this area is basically they are using these visual methods because they are aesthetically more sensitive. They're using this as a potential therapeutic tool to kind of make them narrate their view or narrate their analysis of how they view themselves by using a combination of photo elicitation and narrative analysis. And also they're using mirror gazing to using photo elicitation to make them storytelling and express their views as well. So thank you.
Good afternoon, everyone. I'm Dr. Shaili S. Singh. Let's see why the mind distorts in BDD. Let's begin with a very universal behavior, a glance in the mirror. Most morning, we look, see nothing alarmingly wrong, we get ready and we move on. But occasionally, maybe before a big event, a thought might flicker. Is my nose a little too big? But in a healthy mind, doubt is fleeting. We might glance again from another angle and we feel we are overthinking. We go out, we meet other people, we talk about work, life, and we forget. Even in quiet moments, if the thought returns later, our brain takes the steering wheel and acknowledges that it's an unnecessary worry. Our attention shifts easily and our self-worth remains stable. Now in BDD, say mirror moment is a whole different movie. Mirror is not a tool, it's a microscope. They can't process their whole body or face and are stuck with a particular feature, say with nose itself. Alarmed with this thought, they go out, but even neutral glance are interpreted as disgust, which amplifies the doubt even more. While sitting alone, the commander, our brain, fails to provide any perspective, the thought feels like a fact and distress is real. And so, the cycle goes on. Only relief from this is to check again. The problem is not the mirror, but the brain looking into it. Let's explore this brain system by system. Starting with the first system abnormality, visual processing. Neuroimaging and psychological test findings serve as proxy marker for these underlying brain abnormalities. And here, neuroimaging shows hyperactivity in visual pathways driving detailed analysis, while the global processing system is underactive. This paired with an overactive amygdala creates a brain wired to threat and tiny flaws. This is seen as neurocognitive findings of enhanced flaw detection, poor visual organization, and a reduced face inversion effect, meaning patient process upside down faces well because they already are using detail-based strategy. Clinically, this means patient cannot see themselves as a whole, only as magnified defects. Coming to the another system abnormality, emotional misinterpreter. Functional MRI revealed an overactive amygdala flaring up even for neutral faces. Patients also show altered activity in regions that process facial emotions, like the fusiform and temporal areas. Neurocognitively, they consistently misread neutral or ambiguous expression as angry or disgusted, especially in self-relevant situations. Clinically, even neutral glance feels like a rejection, which deepens their conviction that they are flawed and unlikable. This drives avoidance, isolation, and compulsive reassurance seeking, the core behavior in BDD. Now let's understand the executive dysfunction. Neuroimaging shows reduced activity in the prefrontal cortex, especially the DLPFC. Connections to other regions are disrupted, resulting in the impaired top-down control. Neurocognitive testing reveals poor planning, impaired spatial working memory, deficit in organizing information, and deficient response inhibition. This explains why patients can't reality test their distortion and why they often lack insight. Their brain brakes are impaired. An extension to this comes the most important brain network that's dysfunctional, frontostriatal system. Neuroimaging shows hyperactivity in orbitofrontal cortex and caudate. The OFC sends a constant error detection signal about the appearance, and the caudate gets stuck in a loop, driving the same compulsive behavior repeatedly to try and fix the error. The circuit is overactive and poorly regulated. Patient also shows impaired cognitive flexibility. Clinically, this is why BDD has such an OCD-like quality. The frontostriatal loop drives the relentless cycle of obsession and compulsion. Let's look at the three emerging areas of the research that are expanding our understanding of the BDD beyond the core circuits. First, serotonergic dysfunction. SSRI are the first-line pharmacological treatment, and study shows reduced serotonin transporter binding, pointing to a chemical imbalance. Second is the default mode network aberrations. Its dysregulations likely fuel constant self-focused thought about reappearance. And third, a compelling but still hypothetical area is mirror neuron dysfunction. Key structures implicated in the mirror neuron network have been noted to show abnormal activity in BDD neuroimaging studies. The link between this network's dysfunction with the clinical symptoms of misinterpreting others' emotion is an emerging hypothesis in the BDD literature, though more direct research is needed. Finally, let's look at the digital environment, a powerful pathoplastic factor that shapes BDD in the modern world. Think of social media as 24/7 virtual mirror. It enables constant digital body checking, magnified by filters and editing tools that can distort reality and deepen reappearance or appearance preoccupation. Also, it provides quantified and often distorted validation through likes and comments, which can reinforce both insecurity and compulsive checking. Additionally, algorithms feed users more of the same appearance-focused content, reinforcing referential ideas and trapping them in a loop of comparison. Till now, we have seen BDD as a vulnerability, what are the pathoplastic factors, or what are the pathophysiology. Also, we have seen creativity as a vulnerability. Now let's see how creativity can act as a therapeutic factor.
Good afternoon, everyone. I'm Dr. Neha Karanje. I would talk about how creativity can be a cure or can be part of the therapy for body dysmorphic disorders. Okay, why do we have to talk about it? Why does it matter? Because patients who experience body dysmorphic disorder have high distress, and there is shame and also avoidance. They struggle to verbalize body-related fears, and creative therapies offer non-verbal emotional access for them to bring out the distress and shame they experience because of the body dysmorphic disorder. So, as my colleagues have spoken about the shifting body ideals, and patients who experience body dysmorphic disorder having heightened aesthetic sensitivity, perfectionism as a vulnerability factor, and also we've seen that detailed focus processing and disrupted mirror neuron and other neurobiological factors affecting BDD, and also social media amplifying distortions, comparisons, and self-surveillances. So here we want to use this same aesthetic sensitivity and the various detailed focus processing, which is a vulnerability which can be transformed into a therapeutic strength through creativity. So how can creativity be therapeutic? So here I'm going to talk about various therapies for as a therapeutic medium for body dysmorphic disorder. And the question we all think about is, do we have to be good at art to involve or to engage in art therapy? The answer is no. Art therapy isn't about making beautiful art. It's about using the creative process to heal, express, and understand oneself. So as I've just discussed about it, it transforms the aesthetic sensitivity into strength, externalizes the intrusive and shame-based thoughts, engages mirror neuron pathways via embodied practices, and shifts detail fixation towards holistic body processing. So, and also allows symbolic expression where verbalization is difficult, and also helps in emotional regulation. So various creative modalities that come under the umbrella of creative art therapies include drawing, coloring, painting, music therapy, body positive poetry, journaling, dance, movement therapy, drama therapy, and various other body positive initiatives. So some of the examples that I found very interesting are live drawing classes, which have been an initiative in Bangalore, and that really focuses on the function and form over appearance. So it transforms how you look at a person, not just the external appearance, but how you can artist, how when you draw a person, you understand the various forms, how the shadow falls on the person, how the angles are. So every person is unique. So that's a transformative process. And some other unique things that I came across is this scar tattooing and also glittering over the stretch marks. So why do people do it, or what does it mean? When I went through it, what I found was art shifts focus from flaws to meaning, helping clients reinterpret scars as a part of their lived story. And the other therapy being poetry, used as a medium to reshape body narratives. It illustrates, the illustrations can normalize real bodies, and poetry lets one rewrite the inner script. So I also came across doll making art therapies, generally used in geriatric population, but however, it can be used for body dysmorphic disorders. One becomes the creator and not the critique. So there is a role reversal which is powerful. And also the movement therapy, it is psychotherapeutic.
We have 5 minutes more because at 1 we have to close.
Yes. So helps improve body image and emotional regulation. So there is the International Association of Dance and Movement Therapy. They say it improves it releases the tension and sensation without judgment. It helps to express emotions freely, reduces self-criticism, enhances social connection, and collaborative and creative activities. It promotes body acceptance. So coming to evidences, there was a systematic review in 2025 which says that creative art therapies improve body perception, awareness, and emotional well-being. However, studies in this area there is a deficiency in studies in this area. So there was an RCT which I looked through where it was used for movement-based art therapy in women suffering from polycystic ovarian syndrome. So it was an RCT where 30 women who around 101 women were screened, and 66 met the inclusion criteria. Age group was between 18 to 64 years, women between 18 to 64 years, and who suffered from polycystic ovarian syndrome. 30 were the intervention group, 30 were the control group, and it was found that there was significant improvement in body image scores post-intervention and 1 month follow-up. And also the other study was done by Cog et al. So there was moderate efficacy in movement-based therapy. It was a meta-analysis. It was a systematic review. So there are evidence gaps in art therapy because of the small database, and there is heterogeneity in the therapies used, like music therapy or drama therapy. So there is heterogeneity in the various modalities used, and small sample size, inconsistent measures, short follow-up. So these were some of the limitations of the studies that I have quoted. So the future directions would be to integrate creative art therapies with the other therapies for body dysmorphic disorder like CBT, etc., and to build digital or media literacy interventions and to promote community body acceptance art projects. Thank you.
Okay. Thank you very much. We request all 4 of you to maybe come on the stage and a quick 2 minutes Q&A, because individually you all didn't get a chance. So it's a half an hour's slot. Just 2 minutes more. If any audience wants to ask any question or comments, then we will close it.
The important thing about this is that you have chosen a right kind of clinical entity to discuss at this point. Rightly pointed out by the last speaker, the psychodrama can be of great help. Jacob-Elmerano theory talks about 3 things. That it's not only about, psychodrama is not only about drama kind of thing. Drama has 3 components. One is physical, another is emotional, thinking process.
Sir,
then,
as you are the expert, you please come here and speak. No, you are the biggest expert. आप उधर से बात करिए.
Thank you. It's an honor. So, no, Jacob-Elmerano theory we discuss. So it talks about your body is involved, your mind is involved, and you are connected to people. So 3 things done together. What happens in body dysmorphic disorder? Shame, guilt, all these things are projected to body parts. And when you do there, so your body is active, your mind is active, and you are connected with people. So even if you are short height, somebody is Lawrence, somebody is Hardy, doesn't matter. Both are stars. So you become star in your, at least in your the company you are working in. So that helps a lot. So if you write paper, you can write at length. I will add one very interesting story. There was a poet from my state, Bihar. His name was, pen name was Vikat. So when he used to go to recite poems, so usually mics have to keep very low and very down. And in those days, we were not having such kinds of mics. So in that kind of mic, when everything has to be lowered and up. So there was a China war happened. Sorry, Pakistan war. First India-Pakistan war happened. And there was a poetry recitation function in Delhi, where Lal Bahadur Shastri, then Prime Minister, was also sitting. When Vikatji went for recitation, mic was lowered to zzz. Before that, some tall Urdu poet was reciting. Mic was lowered zzz, like this, and people started laughing. You see how he managed. He said, Vikatji said, "Mere kad pe na haso, don't laugh at my stature. Mere kad pe na haso, ye kad hai wahi jiski laaj Lal Bahadur ne rakhi." Lal Bahadur Shastri was also of short height. So you see what kind of sublimation process you can see here. And he connected to Lal Bahadur Shastri. He connected him to everybody. Height is not important. So creativity, how can help in overcoming is an example. Keep it in your mind when you're writing a paper, because such anecdotes make papers entertaining. I congratulate you all for a wonderful symposium. Thank you.
Thank you very much, sir. And I think any more comments from the audience? Anyone would like to say anything or would like to ask them a question, or then we can conclude the session. Any more questions from the audience? Any comment?
I have a question. Since this was a very interesting symposia, even when it was being submitted, what the scientific committee was looking at was taking symposia presentations relevant to the theme, and this was one that stood out. And of course, Dr. Harish Kulkarni earlier was talking about movie reel review as well. So what inspired you to talk about body dysmorphia disorder and psychodrama and these aspects? Are you coming frequently across such patients in St. John's maybe?
Yeah. So we do come across, we have a cohort of these basically young adults who are social media influencers and who have usually a comorbid eating disorder and associated body dysmorphia as well. But we also have very few instances of them using it as a therapeutic tool themselves as well, like these body positivity initiatives of like how Neha was talking about the stretch marks, or making some art using that, or converting it to a tattoo and things like that. So we wanted to explore more and look at literature, what has been said, and also look at specific personality factors which can contribute to or which can lead to this, and how it need not always be a vulnerability, it can be used as a virtue as well. So we wanted to focus on that part.
Thank you for presenting this session. Now I'd like to request Dr. Vinay Kumar sir to felicitate our chairpersons. And we'll all have